Okay.
Morning to everyone. I'm Anderson from Brazil.
Right. Okay, I gotta put a like on that. Okay. Oh. Whoa. A dog.
How are you?
Dog. I hope we're not getting dusted.
Yeah?
Yeah, this is weird because I'm communicating with his associate and they're not answering.
Oops.
Yeah, it's like, oh. So yeah, WeChat's nice because it goes boop when you get a message.
Yeah.
So I keep one computer open to WeChat. But well, there's certainly going to be talent in the audience to present
Yeah.
if that doesn't happen. So we'll see what Ike wants to do. I keep in contact with Ike by WhatsApp. Okay. Yeah, dog. Oh, God. I'm sure in television, yeah. Maybe I'm getting nervous. Ike says, chill.
Yeah,
Dog,
it does show up, I think.
yeah, dog, your screen froze. Are you on Wi-Fi?
No, I turned off the picture.
Oh, okay. Yeah, I guess this must be what it's like in neurosurgery.
Yep.
You go, oh. Dog, can you hear me?
Yes.
Yeah, I'll just send something in a personal chat, okay?
Okay.
Kde? Z toho bazénu? To je blbý. Aha. No, jo. Nejdu. Nemluvím, ale jako se Aha. Start video. Jo.
Hello, Vlad.
Hello, John.
How you doing? You got in okay? Okay, I see.
Did you get the file from the cloud?
Yeah, I got all the files, and
Good.
later on we'll go through them. Put them in order and everything.
Very good.
So, you have a nice study all those books.
Yeah,
And you probably read them.
I did.
They're not just for show.
Good. No ale ono to docela funguje. Jsem se tam napojil. Takže tam No, never done it. I never done it. You have it done that. I wish it was. Everything people do that never go over the short. No, dneska zákona to budu jenom dívat, protože abych se to jako přikusil. Ty přednášky takhle udám. Tam tak, no. Jdu se zase přidružit. Tím tam mám.
A tak to můžu říct jí Bože ahoj.
No, ten tam ještě není.
Hello, Abraham.
Dr. John, how are you?
How you been?
Good, good. It's been a while since I've been here.
Yeah, you've
Right.
been busy, obviously.
Yeah, I've been working in the neurosurgical OR
Oh, okay. In Berlin?
in the northern part of Turkey.
Oh, okay. Let's see.
Tím neznámý, počkej, tak já se asi ještě.
Hello, Ibrahim. How are you?
Hey, how are you, Manuel?
Long time I don't see you too.
Yes, right. Are you in Moscow?
Yes,
Yeah,
in duty today.
all right. How's the situation?
11,000 cases. And almost 70 in there.
All right.
But it can be worse.
Numbers are rising, right? So,
Yes, everywhere. How is there? You in Germany still, right?
now I'm back in Germany. Yeah, I came back from Turkey just 2 days ago.
What are you doing there?
Well, just working, visiting a professor.
Oh, nice. You're in what year of medicine? Or you finished?
Well, now 5.
Nice.
Yeah. see, we'll probably have online courses this semester.
Yes, I think on these times the online education gonna improve a lot.
Yeah.
Okay, we're just getting through to Yuha or his secretary. Hey, Manuel.
Hello, John. How are you?
Good. How you doing?
Oh, good.
We may be a few minutes late starting because I'm communicating now with Yuha's secretary. So, welcome everybody. Take good care of your mute button, unless you're talking, of course. Okay. Okay, I think. Hello, Sen or Yuha, are you there?
Yes, of course.
Hello. Sen or Yuha?
Oh, I'm here.
Oh, hey, how you doing? All right, we made it. Great. We haven't started recording yet. That's the man in the background.
Share for.
Hey, good morning, Yuha.
Hello, John. Hello.
How you been? We haven't started yet. Waiting for I. Hello, Khalif.
Hola, hola John, ¿cómo estás?
Bien, tú. Oh, people from all over the place. Vietnam, Bangladesh. Someone needs to mute. Dr. Samir, you're back.
Yes, I am with you.
Okay, we haven't started yet. We start in a few minutes. You
Sure.
can say hello to Yuha, though. Yuha, Dr. Samir is here.
Hello.
Okay. Okay, just wait and try.
Petri, it's hot. Can you take it?
If I was a good producer lad, I'd have some kind of video playing now, like a nice scenery or something. Okay. Hey, Ike's on his way. Okay. Hello, Ike, you here? There you are.
Yes, John. Is Yuha around?
Yeah, he's here.
Okay, let's start, John.
Okay,
Where is
ready?
Yuha?
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. It's Dr. John Bennett from Miami Beach, home of Neurosurgical TV. It gives me great honor to be introducing Yuha. Well, not as everyone knows him, but to be doing a show with him. And it does me also a great honor to turn it over to Ike to run the proceedings. Hello, good morning, Ike.
John, good evening. And Yuha, it's an honor to be introducing Yuha. Yuha is one of my greatest friends, my guide, and man who's been in Viratnagar for 1 year, almost a year. He's one of the legends of vascular neurosurgery. If you could mark out 5 neurosurgeons in this century, as the neurosurgeon of the century, Juha would be one of them. So he is, well, I don't have to introduce him to anybody. Everybody knows him. So it's been such an honor to have him around. And I'm sure all of us will learn a lot from him. Let's start on with it.
Okay, thank you,
Okay.
Jaip. Thank you, Jaip. Hello, everybody. So I will speak about brainstem cavernomas. I will show 6 short videos and comment on the indications and outcome. with these. So principally, brainstem cavernomas are more eager to pleat, replete, and so you should be rather active in operating on them. But of course, they are inside the brainstem, so the operation might be demanding. And most difficult thing is to find them. So if you see that they are, one part of them is superficial, you should go there, and you will be happy when you see the yellow color on the surface, then you know you are there. But if you don't see anything, then you may get desperate. MRI pictures are very important. So you may localize the lesion with the cranial nerves and vessels, arteries. So there are some landmarks. I have not used navigation, or I have used, but because when you open the posterior fossa, then you take CSF out, then there is a shift and you will not be doing so well with navigation. But you can do it, but don't trust so much. So trust more on the anatomical landmarks. So let's go to the cases. So we will connect to the cases. Oh. Okay, here. No.
Oh, which one?
Yeah. Okay, I can do. Here is a. Can you make it bigger? So these videos are from the collections 1001 videos. You can find them in internet by my name and typing 1001 1001. This is a 36 years old female, and with ruptured medulla oblongata. Can it go to beginning so people will see the lesion once more? Go to beginning. We begin once more. So because we had some technical difficulties now. So these cases were operated on in Helsinki, here in Chengzhou, China. I have done maybe 15 brainstem cavernomas, but I don't have set that kind of good videos of them. So this is 36 years old female with this lesion, and you see that it's coming superficial. And this patient in park bench position, and we make a retrosigmoid approach. I like to open here under microscope so you will identify the vertebral artery better. Then you make a small flap here. And now already opening the dura. Some stitches. This is cisterna magna. And here, now you are already happy because you see the yellow color here. So it's the yellow color. Then you have to select a good place without vessels. And then you go with a very sharp forceps inside and treat a little bit the opening, and then go around, and sucking the blood. I like to operate them rather soon after the bleeding because it is more easy to find them. This is my practice. And then you go around the lesion, and then you take a forceps and good grip on the lesion. And this, like a bird, is coming out slowly, very tenderly. It looks terrible, but it is high magnification here. So now it is coming out, and you don't lose the cavernoma, just slowly draw it out. And the best thing is if you can take it in one piece, but not always it is coming in one piece. So when you have a good specimen out, then you have to check, carefully check, and don't coagulate so much. Don't coagulate so much here because you are inside the brainstem. You should not take all the walls of the here because you are inside the brainstem. So just make a good hemostasis, check that no cavenoma is left, and you see here is the magnification. So it is around 4 or 5 millimeter the opening, and I used to inject tissue glue in the cavity. And now we see the situation, and then we are going to closing, and these are postoperative pictures. You see the cavenoma is out. Then we take the next one. Brainstem cavenoma also, yeah, it's coming here. Good. The videos were edited mainly by Johan Choco. He's Velasquez. He's from Peru. This is a bigger one. And here you should go from the left side because this is most superficial. Here. So again, park bench position, this is mastoid, and left retrosigmoid approach, short incision. And good retractor, another smaller one. And then after craniotomy, opening the dura, some tissue glue to stop the epidural bleedings. And again, we go lateral, cerebellum, open cistern, taking care of the cranial nerves. And here we see the vertebral artery. And now carefully checking. This was not so superficial as the last one, so it is not so easy to identify, but here you maybe see some yellow color. Yeah. Then you select a small area where there are no arteries, and then you can go inside. Here with sharp forceps, going inside. And here, if you don't find, then 1 millimeter is like 1 kilometer. So, and then when you get some blood out, then it is wonderful. You have to check carefully that you have fresh MRIs. I was operating in Mexico City, and there was a good cavenoma, but I couldn't find it, even it was a big one. So the pictures, MRI pictures were old, and now in the operation, we could get some blood, but not real cavenoma, but we were in the right place. As the next day MRI showed, we left a small clip there. So we were totally in right place, but the pictures were 9 months old, so the hematoma had resolved, and so in the operation we couldn't find. Here again, pulling out with good forceps. And this is the bigger one, so it is like childbirth, now coming out. But you should not be happy with this result. You have to check the cavity walls carefully. There might be small parts of the cavenoma left, or baby cavenomas. So you should be careful checking all the walls of the cavity, going with the microscope around. But you should not clean the cavity walls, take the cavity walls out totally, as this is brainstem. But to go around, when you have some walls in the cavity, And here I put the clip. Why I put the clip there? So that they believe that I have been there. And another thing is it keeps some artifacts. And this is based on one patient whose brainstem cavernoma was operated totally, like I thought, but two neurologists said there is a remnant. And the patient, here is post-operative, some blood you can see, and you see the clip. So the patient was told that there is some cavernoma left, and I was made a reoperation some months later. I couldn't find anything, but I caused the patient facial nerve palsy, so this was very unfortunate thing to reoperate because it is difficult. You have scarring. It is only one time you can go well inside the brainstem. Here, we didn't have the pictures in the beginning. This is also brainstem cavernoma. No, what is that? This is cerebella. Stop that. Here is a pontine cavernoma. Take this one. Pontine, number 6. Number 6. Okay, sorry, it was a cerebellar cavernoma. So this is now brainstem cavernoma edited by Russian fellow. He's now working in as a fellow in Israel. Here we see that the cavernoma is protruding inside the fourth ventricle. So exceptionally, we go now through the fourth ventricle, and the patient is here sitting. I like to have sitting position. I have operated extremely high number of patients in sitting position. We had a good team, and we could build the sitting position very well. So here we go between the tonsils, and now you see the cavernoma is coming to the surface here. Of course, when you go here, you should go as lateral as possible. And now I'm using water dissection to tenderly dissect the cavernoma out away from brainstem, and then very carefully again water irrigation, and then very carefully drawing back. Even it looks under high magnification, it looks that the manipulating a lot the brainstem, but brainstem is because of the cavernoma and bleeding rather tolerant, and usually the patients are doing extremely well after operation and recover well. You may produce some new deficits, but they are transitory. So after 2 months, the patient is good condition, but usually they are doing better than before operation, especially if you operate as emergency with large bleeding. So they do better when to take the hematoma out. So there's another policy is to wait 2-3 months and make a new MRI of these cases, but I didn't like this policy because the bleeding helps you. This Sylvian aqueduct, you see there up. So the fresh bleeding helps you in finding the cavernoma, and when you take the blood out, then you are in a good cavity, and then it's more easy, I think, to take the cavernoma out. There's certainly many discussions now. Now there is a study asking different neurosurgeons what is their policy, and it seems that the outcome of these policies are rather, most neurosurgeons have the same opinion nowadays with advanced microsurgery. So Now this is a taco seed, what I like, good hemostat, and I leave a clip here. Here in China, I'm not allowed to leave a clip. So they scrub nurse is immediately saying it's not allowed. So now continuing. There's some remnant, and I left 2 clips there. Making good hemostasis. This is Sylvian aqueduct again. Here the measurement was rather large. Cavernoma coming to the surface, and use fibrin glue also for hemostasis. This is post-operative picture. You see the clips there, and this is the cavity. The patient made good recovery. Then number 7. This with the Chinese fellow has edited this pontine cavernoma. This is higher than the former ones. And again here, you have to go to place where it is most superficial. Here we go again, retrosigmoid approach, lateral suboccipital approach on the right side. Making a small flap, detaching the dura with Yone dissector, and then using the side cutting craniotome. And then breaking the bone flap, and then with hot drilling, diamond drill, taking bone to come more lateral. And again, here we go besides the cerebellum, retracting the cerebellum medially and upwards. And here we open a little bit more dura. Okay, now it was maybe a little bit tight. I went to see the 5th nerve, and now I don't see now any yellow. Oh, there's some yellow area. Now we go inside. You have to be careful with your angle. So you have to go directly inside the cavernoma. If your angle is wrong, then you will not find the cavernoma. Here the cavernoma is coming. And good grip on the cavernoma. Don't lose your grip. So, and don't pull too hard. Now it's coming slowly, but I think one part of the cavernoma is left here. Yeah. But a big part. The measurements, and again hemostasis, and this is the cavernoma. Then we have number 8. No, 8. This one. Okay. This fellow from Hong Kong is working now in Hong Kong. Continued working. Pontine cavenoma. This is at the level of the 5th nerve. Again, right retrosynchron approach. Here, lumbar puncture to take CSF out, and this means already a brain shift. Breaking the bone flap, taking with diamond drill, laterally bone, and then opening the dura. Stitch. Second one, they should pull very tight the dura. One more here, and then we go again. The 5th nerve on the right, 7, 8. And now we have to go rather anterior because the cavernomas locate the anterior, but you saw the yellow color here, so we are going around the cavernoma here. And detaching the cavernoma from surroundings, and as much then you can get a good grip on the cavernoma. Here now with the forceps first. And then this is a hook. This is a hook. Hooks are dangerous instruments in microsurgery because you might take it in wrong direction out and have something listen. So I don't like it, but sometimes you are using everything because this was more anterior on the ventral surface of the pons, so it's more difficult to have a good angle to take it out. You can discuss a more lateral, far lateral approach. I call them enough lateral. I take enough bone out, but usually don't go extremely lateral because there's one trick where you can see very lateral, you take the table high and look below the bone. And there's one more. Yeah, this one. Okay. Yeah. There is a pontomedullary, this is rather low. This is a very delicate situation here in Chengzhou. I operated extremely large pontomedullary malformation, was extremely terrified because it took nearly all the medulla oblongata. The patient was when coming tetraparetic and after operation, but he made very good recovery, but took long time to recover. Here again, simple lateral suboccipital approach, but going more low now. And then checking the vertebral artery with Doppler. Small opening, small flap done, and then drilling bone at the foramen magnum.
Yuha, I cannot see the video. I cannot see the video, Yuha.
Okay. The other ones you have seen? What's wrong?
Yeah.
No,
Other ones I have seen. Other
cannot
ones I
see
have.
any video.
Okay, okay.
Yeah, the other ones were fine.
Okay, this is the last
There you go.
one.
There you go.
See it now?
Yeah, now
Yes.
start.
Yes.
Okay, okay. This is the opening of the dura. And as mentioned, this is lower than the other ones. This is pontomedullary cavernoma, checking the vertebral artery, again with Doppler. And now going there, now I saw quickly something yellow, promising yellow. Yeah.
Yuha, still now the
The
operative
image
video is
is
not
freezing.
going forward. It's not going forward.
It's not going forward. What happens? Here it is okay.
Yeah, thanks,
Yeah, I
for
hear.
noticing that.
Is it now okay?
It's staying still. There you go. Well, still not moving.
Here we go to the beginning.
Okay.
We take again.
Okay.
Close and we take it. This is the last one. So. Okay.
Good old tech.
No, I don't know. This is Chinese.
You might have to click to an earlier time just to get it rolling.
Short videos, short, and then cover number,
Okay.
and influence. This one. Okay, it's coming once more.
Okay.
This one. No, it's okay. It's okay. It's running now.
Yes. Yes, it is.
Okay, pontomedullary recover node malformation. Like I told you here in Chengzhou, Henan Provincial People's Hospital, I operate one young patient with third bleed with huge cavernoma, by far bigger than this one. It was taking nearly all the medulla oblongata. The patient had severe tetraparesis before the operation, but he recovered then in 6 months, very good state. So, but I was extremely stressed after taking the cavernoma out, because nearly no medulla oblongata seemed to be left, but he recovered well. This is the usual thing. So the cavernoma, when it's bleeding, are pressing the tracts other ways. It is the same. Then you have a medulla oblongata or cervical ependymoma. You take it out, then seems that you have taken everything out. Only a sausage cover remains of the medulla, but the patient is doing well. Then with diamond drill, opening the foramen magnum and now opening the dura. stitches, taking the dura very lateral and then going in the same way than in the former cases, pushing the cerebellum, now stopping again. What happened? There's something wrong with it.
Where is this video?
Mhm.
This video has some problem.
Okay, it just it was running here well, but can you go to the?
Okay, start again.
Okay, now we are taking the cavernoma out after going inside the pontomedullary
It's
region. And can you see it?
yes.
Now, good grip on the cavernoma and then slowly taking it out. See the yellow color? This is, if you see the yellow color, then for me, the operation is nearly done because the localization is the most important. So it means that if the cavernoma is totally in the middle of the pons, there's no good place where it is coming superficially. You should think very carefully if you can take the cavernoma out. In these cases, if there is a bleeding, it helps. But if you have a long time after bleeding or unruptured cavernoma in the middle of pons, so you should be very careful. Of course, the patient age is also important. So I operate always under highest magnification of the microscope, and this gives good view, and your movements are more restricted than under lower magnification. Here I coagulate. Usually you should keep the coagulation minimum, but if you see, of course, small artery, usually 1 or 2 arteries going to cavernoma and then some veins. But actually the cavernomas are ideal lesions to take out because they are not highly vascularized like AVM or vascular tumors. So checking, yeah, this is one perforator coming from the pica. And now putting tissue glue and again measuring the how big is the opening, so maybe 5-6 millimeters. Hemostat, and this is post-operative picture. So these were the cases I wanted to show. I think these are good cases to operate on, and it means that you have to discuss with the patient and family carefully before the operation. You have to discuss carefully with the patient and family the operation. Many of the cases I have operated here, they have been in Beijing and Shanghai, and they were not accepted for operation. So it is difficult if the major centers are not accepting for operation, but they were usually, the patients go usually to Beijing and Shanghai and then come back if they don't get the operation. So I think many cases are not done in China because of the somehow traditionally the Chinese neurosurgeons are afraid of these operations. I think they are good cases to operate on. We should be active in now in the microneurosurgical era with these cases because you have good results in treating these patients. So if you have some questions, or I'm ready to answer. Thank you very much.
Thanks you very much. Juha, Ike, do you want to kind of run it from here?
Yeah, Juha, excellent as usual. Excellent talk. Well, I've been with Juha for quite some time, so I don't have much questions. I know his technique. I've seen it very many times. Vlado, Dr. Spee, other guys out there, do you want to have some questions? Go ahead. Vlado, good to see you.
Good to see you too. Juha, can I ask you? You said rather early. What do you mean by rather? Days, week? To operate on them rather early after the bleeding. How early?
Even the same day if they are in coma. So some
Even
cases.
the same day?
Yeah, as emergency I have operated. So because if they have big hematoma inside the brainstem, so and the patient is unconscious, so I think it's a good indication to operate on. They have done well. Different from the hypertensive intracerebral hematomas. I operated many of them also inside the brainstem, hypertensive, but they went extremely badly. So it was a terrible outcome. So you had they remained with severe deficits and died 2-3 months later in respiration and never. So I stopped to operate on them. Cavanomas are good cases to operate on emergencies quickly after operation, after bleeding.
Next question. Can I, Juha? You hear me?
Yeah, I can hear.
Juha, what about the venous anomaly? Quite usually, quite in all cases, or almost in all cases, you encounter one. Do you check prior to surgery where the veins will be?
In these cases, you didn't have any venous anomaly, but of course you should preserve it. This is one of the
Sure, you should preserve it, but you should know about it. That's that's the most important feature I always look for when I'm checking on cavernoma on MR. Where are the veins? In brainstem, almost all of them have some venous anomaly.
You are right. So we should preserve them. But in these cases, I didn't see any venous anomalies. I don't know if they are more, they are less frequent in brainstem cavernomas. I should check all the other videos. Dr. Juri Kivelä made his PhD on cavernomas in Helsinki. There were around 400 cases, so we should check his PhD how many. Usually there are 30-40% are given by venous anomalies, and we should preserve them. So this is demanding, more difficult than to take the cavernoma out, is to preserve the important vein, because then you have venous infarction. This is what keeps deficits.
Okay, more questions, comments? Now's your chance. Go ahead.
Yes.
Go ahead, Joanne.
Hello.
Joanne. Go ahead, Joanne.
Yes.
Hello. Hello, Dr. Bennett.
Greetings.
Go ahead, Joanne.
Okay. Greetings from Finland, and first of all, my great respect to Professor Hernesniemi. Terveisiä Suomesta. Todella upeaa tavata näissä merkeissä.
Mistä sä olet?
Mä oon Helsinki.
Okay. Greetings to all.
Yeah. Yes, and this bilateral and inaplateral approach was actually my end work also. So you have been my greatest inspiration of this in aneurysms. I have one quick question regarding this post-operative MRI. Because some hemosiderine can be left behind, what are the parameters in order to see it so that it is a residual of cavernoma, or what are the parameters that it's actually allowed? Because in brainstem, like you, Professor, mentioned, it's a place where you cannot really touch too much. Thank you.
I should be very careful in trying to take everything out what you see there. So you should take the cavernoma out and then check the cavity, but don't take everything out that looks brown or hemosiderine. Then you have big deficits in the patient. So you have to leave something there. And I told you about the one patient where 2 neuroradiologists said that there is a remnant, and the patient asked for reoperation. I was stupid enough to go inside, because to go second time inside the brainstem means that you have scarring, and it is more difficult, by far more difficult. And the patient got the facial nerve palsy from my reoperation. I couldn't find anything there. So after that, I have left the clip, give some artifacts, so you cannot sure say if somebody cannot sure say that there is a remnant. It is easy to say there is a remnant, but to take care of the patient who thinks there is a remnant is more extremely difficult. So the first operation is the most important, and checking carefully the cavity, and if you have the feeling and touch that the cavernoma is totally out, then you should trust on you and go forward and follow up the patient. I had one case here, in Chengzhou. I had one case. I thought I took the pontine cavernoma by subtemporal approach, totally out. The patient was coming 1 month later with a big bleeding in the same place, and I operated again, and that was a remnant. And this is the only case of around 100 brainstem cavernomas that has replayed. So it was here in China. So here in China, it's very difficult to confirm the patient to a new operation. By far more difficult than in any other place. So, but I was talking with the patient, and he made a good recovery after operation. In 1 month, he was doing extremely well. Even he had severe deficit after the bleeding. So this is the only case I had a repleading of the operation.
Thank you. Thank you so much, Professor. Thank you.
Very good. More questions, comments?
Yes.
Go ahead. Hey, Dr. Svea.
Hello. Hello. I just want to take this opportunity. Can you hear me?
Yes, we can.
I'm sitting here at home in Jordan, where we have lockdown nationwide. I'm sitting with my daughter, who is a 5th year neurosurgical resident. And I just want to take this opportunity to thank Professor Juha for disseminating his knowledge, disseminating his experience with the people. And on behalf of the doctors and neurosurgeons of Jordan, I'd like to thank him for taking so many of our residents and fellows for training. I have 3 questions, actually. First one, does Professor Hanasemi use evoked potentials, motor evoked potentials, sensory evoked potentials, or brainstem observation during the surgery?
I have not been using. I know many are using. They feel that this is extremely important, but I have trusted more on the anatomical localization, and my thinking is that you have to take the cavernoma out if you want to be somehow radical and help the patient. So the most important is the localization, and then taking the cavernoma out. And in my cases, the patients have done extremely well. When I see the videos, it looks that I'm manipulating a lot, and shaking the brainstem and pulling the cavernoma out, but the patients are doing extremely well. So
I totally
I have
agree.
not
I have
been
another.
using. I have not been using. Yeah.
Sure. I have a second question for you, and I don't believe in the use of gamma radiosurgery for the cavernomas. What's your beliefs about this? How do you think about this? Do you feel there is any place?
For some reasons, these cavernomas are not reacting. They should be ideal ideal targets for gamma knife, but they are not reacting. So we should operate on them. We should operate on them. Now I cannot hear you. I cannot hear you.
Go ahead, Dr. Sabea.
Yeah.
I use the sitting position in posterior fossa surgery very often. I'm very experienced with that, so I have been using it for tens of years or hundreds of patients. What's your views in the comparison between sitting position and park bench position? Which one do you prefer?
My practice has been that if the lesion is lateral in the posterior fossa, or you can go laterally. So I use lateral suboccipital approach, but then when the lesion is in the midline, parieto-occipital, pineal, and then cerebellum in the midline, then I have used the sitting position, especially in pineal lesions, but in the fourth ventricle lesions, midline lesions usually. So this is
Thank you. Thank you very much.
Has been practice in Helsinki. We had a doing very well in sitting position. Usually, when you go to a different place, then every anesthetist saying terrible, we cannot do it. But even here in China, we could do some cases after.
Right.
Okay, Khalid, I'm sorry. Khalid, Ashur, you have a question?
Yes.
Go ahead.
First of all, thanks for this very interesting cases, Dr. Joha. And my question is, how frequent do you have remnants, adenoma remnants, and what are the adjuncts you use intraoperatively to check for remnants? Do you use intraoperative ultrasound? Do you use intraoperative MRI? What exactly you use to check for any remnants?
We didn't have in Helsinki and not here in China or Nepal or in the places in the world where I had never access to intraoperative MRI. So I have only checked the cavity carefully under the microscope because I'm using the mouth switch. So it is, the microscope is very mobile. So I try to think that this is a ball. I have to see all the walls of the ball and take every suspected remnant out, but not to be too radical. You have to leave some walls in the cavity. Otherwise, you have deficits. I have no access to it and no experience on intraoperative MRI. I don't know any other ways to check the remnant than the microsurgical observation vision checking.
Hey, Zolo, you had a question?
Juha,
I'm sorry. Go ahead.
You had access to intraoperative MRI in Nepal. It was a 3 Tesla intraop MR, but I've never seen you using it because you never needed it. But I must correct you. I must tell you that you had access to intraoperative 3 Tesla MR.
Okay. I'm sorry. I don't feel so familiar. It takes for special cases. It certainly might be good, but I think it is for the future generations to use it.
Speaking of future generations, Zolo, do you have something to say? Go ahead,
Yes,
Saul.
Dr. Ben. Yes, good morning to everybody. Good morning, Professor. Thank you very much for the presentation. My question is, is there any indication to the usage of steroid before a surgery in this case? And if yes, for like how long? What is the duration prior to surgery to use the steroids? Thank you.
I have not been using steroids in these cases. I don't think it is necessary. And it might be also dangerous because you might have gastric ulcer. I think my thinking is that these cases might have more ulcer with steroids, but I'm fear to give them steroids.
Okay, very good. Next question.
Hi, I have a question.
Go ahead.
Okay, my name is Dr. William. I'm calling from Nairobi, Kenya. I just wanted to ask Mr. Juha, how does someone develop the dexterity, the manual skills to be able to work at such depth with a microscope and still be able to keep up with the other neurosurgical workload, like the general neurosurgery stuff? What's the regimen you use to train people to work under a microscope on the brainstem?
This is difficult how to teach. I think if you can, I have used always since '82, after first visit to Yasakil, I have used always the mouth switch in the microscope. So the microscope is very mobile, and one of the how to train, you are closing every wound under the microscope, and then you learn to coordinate your hands well, and this is one of the important things. Begin how to train, close the wound under microscope. This is how we are doing. Here in China, it's impossible to get the people to close under microscope because no one is doing so. And in Helsinki, we used to close every case under microscope, and this is one of the important things to train under microscope. You learn. You have a good 30 minutes to train.
Thank you. Thank you very much for that.
Okay, next question.
Juha, can I?
Go ahead.
John?
Go ahead.
Yeah. You never mentioned unruptured cavernomas, Juha. What's the policy?
I mentioned in the beginning that with unruptured cavernomas, you should be careful. I would operate a young person, 15, 20 years old or 30 years old, with very superficial unruptured cavernoma. But I would discuss carefully. Maybe you could, if the patient is hesitant, then we should go forward and wait for the bleeding. But the unruptured, we don't know exactly if they are dangerous.
Only those on the surface then.
Yeah, then I would, if it looks that it is very superficial and possible to take out, then I would do it, but discuss carefully.
Yeah.
Discuss carefully.
You said you were able to check the whole cavity after the removal of the cavernoma. I never was able to do that because the entry zone is very small and you never see the cavity which is opposite of yourself. You see only the depth. So what we are now doing, we are using endoscope. We resect the cavernoma and then we irrigate everything, and only then we insert the endoscope, and that is the only way how you can see the whole cavity. I don't believe you can see it with the microscope.
Are you using the mouth switch in the microscope?
No.
Then you can go around. Then
you never can go backwards. You never can go backwards. Whatever you do with the microscope, you cannot go backwards. I don't believe, honestly, I don't believe that you can see the whole cavity.
Because this is the cavity. You go here, inside,
right.
You look here, you look here, you look here, and you look here.
But you do not look backwards. You do not see the roof of the cavity. The roof, the wall which is directly opposite to yourself.
So to use the endoscope certainly might be a good idea, and it's improving the results, certainly. So everything what improves the results, you should use. So this is good idea.
Sure.
This is good idea,
Yeah, agreed.
But I have trusted when I dissect the cavernoma out, then I get a good grip and pull it out. So yeah. You are right. You're right. So endoscope is good, but I didn't have so good experience in the 90s with the endoscopes. They were certainly more rough and not so good. So I didn't take in my practice then.
Good.
Nowadays they are smaller and better.
Okay, and any more questions, comments?
Yes, please.
Go ahead.
Thank you very much. I'm Muhammad from Indonesia. I'm a final year resident. First, I want to say sorry because I was late when I was logged into this meeting, and I saw on the last of your 2 video that you put the aneurysm clip on the cavernoma. I don't quite understand the function of the.
It's not aneurysm clip.
Okay.
It is VEC. It is not aneurysm clip. It is VEC clip.
Oh, it's a wedge clip. So
VEC.
where did exactly you put the clip?
In the cavity, inside the cavity. For reasons many, if you operate that kind of impossible looking cases, the people say, don't believe you that you have taken it out. I put a clip that they see that I have been there. And then the second thing is they give some artifacts so that no one, a neurologist is saying that there is a remnant. If they say there is a remnant, then it is better not to go for the remnant if it is not a big and clear one. If there is some small spot of hemosiderin, you should not go for it. It is more easy to say there is a remnant. You should follow up the case and not to go second time. Of course, if there is a huge cavernoma left, you see it immediately in the post-operative picture, then you should go immediately after operation. But in Scandinavia, in Helsinki, you could go next day again if there is a big remnant. Here you cannot do. You cannot. They are so afraid of operations, and this is extremely totally different world here.
Okay, Mohammed Kuzia, you have a question? Mohammed, you're next.
Yeah, it's still me.
Oh, I'm sorry. I'm sorry.
So you were saying that it's to see the remnant. How exactly you will determine if there's a remnant by putting a wedge clip? I still didn't.
You didn't listen to me. You didn't listen to me. I put the clip that it gives some artifacts that it is disturbing a little bit the MRI after operation.
Okay.
I call it dirty trick to protect the patient. To protect the patient, because there is certainly someone who is saying there is a remnant. It's nonsense to say there is a small remnant. If there is a little bit hemosiderin, the patient is doing well, let her or him live forwards and not tell there is maybe a little bit hemosiderin, this is the remnant. This is nonsense. It is extremely dangerous to go to do a reoperation inside the brainstem. This is one of the things that is sure. If there is a big remnant, then it's of course you should see it immediately after operation and go again in the first day, the second day after operation.
Okay.
Thank you very much, Professor.
Okay, next question, comment? Okay.
Hello.
Go ahead, Victor.
Yeah, no questions, just to congratulate Dr. Juha. It was a very nice presentation.
Hello, Victor.
Okay, Duong, is there anybody else on the panel like to say hello to you, huh? Come on, guys, step up. It's your chance to say hello.
Hello, sir.
Hello.
Hello.
Okay.
Hello, everybody.
Hello.
Yeah,
Hi.
yeah, please introduce yourself.
I hope the situation will go well all around the world. I was six weeks here behind the sealed door in quarantine, but I'm doing well. And here in China, the COVID-19 is going down at the moment. Looks so.
Okay, just technical glitches there. Well, I'd like to thank you very much, and we hope to see you more in the future, and good luck in China.
Thank you. Thank you. All the best to all.
Thank you.
World. No, thank you very much.
Good day.
Thank you, sir.
Okay, we're off the air. It's on YouTube though, so. Hype, okay. I was getting nervous, Hype. I guess it's like a neurosurgery, you know, when Juha wasn't coming. Hype, you're muted. You're muted, Hype.
Hello?
There you go. Yeah,
Vlad. Tomorrow is Vlad's turn.
Yeah, we're gonna go over the slides now.
Yeah, I mean, no, maybe he doesn't have to, I mean, rehearse or anything, but make sure he's up to speed on this. Vlad, are you there?
Yeah, sure.
Yeah, we'll just go over. We'll just go over the videos now.
You go over it now, John.
We can do it now if you want.
Okay. Sure will.
Let's give me a minute here for say hello, Abraham. How you been? Oh, Abraham. Yeah, okay. There's Abraham, and who else is here? Aminata just came. Abraham, how you doing? From Russia. Abraham, you there?
Oh, hello, Professor. Hello,
hey,
Doctor.
Yeah, introduce yourself, Abraham, to everybody.
Yeah, thank you for amazing lecture, Doctor and Professor Johan.
Yeah, Abraham's a leader in social media in Russia, Russian Neurosurgery Group. Are you still staying active in that, Abraham?
What, Doctor?
Are you still staying active in social media during your first year of training of neurosurgery in Tyumen, Russia?
No, I sent these other guys, and I thought all the years, and these other guys.
Okay. Well, listen, we need to do more Russian conferences.
Okay, it's a great idea.
Okay, okay, I'll try to get a hold of Albert. Okay.
Yes, okay.
Vlad.
Yeah.
Vlad.
Yeah.
So tomorrow first talk would be Parthiban, 1 hour, 5 to 6, and then 6 to 7 or 6 to 10. You can go ahead and keep talking.
Yeah. No problem. What is 6 to and what is the time difference? It's like 3 and 45.
See, what you had started this, the time that you have started will be the time that Parthiban will start tomorrow.
Okay, so tell me what is the time at your place now? Because I have 2:40 p.m. And you?
It is 6:30 here.
6:30.
Yeah.
All right. So say that I shall be on 5 your time, or?
Yeah. So 5 my time should be fine.
Okay. Hey, Ipe, everyone's going to get to see us arranging Vlad's talk for tomorrow.
Yeah.
So
but I need to arrange it with you, John.
Everybody, they're going to watch behind the scene work, Vlad.
John, that will be private. John, I need you to do it private, okay?
Oh, okay. All right.
Yeah.
Okay.
And you have a separate session with Vlad. I mean, and also Parthiban will be doing the first talk. Vlad will be doing the second talk. And if Vlad wants to do another talk, it's fine. And also Yuha, if he is around, if he can do more talks, will be very welcome. So Vlad and Yuha, any number of talks, number of talks.
Yeah, I'll tell that to his secretary. Yeah, well, what's your time, Vlad? Are you can you wait? Can you wait a bit?
2:40 p.m.
Do you want to meet around 4 o'clock your time? Are you busy today?
4 o'clock my time, okay?
Okay, so in an hour and a half, right?
Right.
Okay, I'll see you. Then we do the
tomorrow.
work.
Tomorrow. You are talking tomorrow, John.
No, now.
No,
Today. So in about an hour?
Yeah, but an hour is good. I'll send you a link.
Send me a link. All right.
Great.
Thank you.
Okay, great.
Okay, guys.
Thank you. Stuart.
Yuha, thank you, Yuha. Thank you very much. Is Yuha still there?
Eva wants to greet you.
Hey.
Hello,
Hey.
Hey. How are you doing? Hi. Is family okay?
Fine.
Hello.
Hello.
The youngest.
Hey.
The younger one.
Hello.
Hey, Fitri, how you doing? Fitri. How is that? How is it?
Yoko, Michael.
Hello.
Vlado.
John,
Yuha,
you
Fitri, everybody.
should give us some links or
Yes, it's
Good to see all of you. Good to see all of you. Good to see so much. So good to see all of you.
good.
Bye-bye.
Bye-bye. Till
Take
tomorrow.
care.
See you in an hour, Vlad.
Bye-bye.
Yeah, bye-bye.
Bye.
Bye.
Yeah, bye.
Huh? Vladimir too.
Okay, John, send me a link.
Yeah, okay, well, I'll see you in an hour, Vlad.
See you in an hour. Bye-bye.
Bye-bye. Anybody else there want to introduce themselves? We're not record. We're on YouTube. We're on the air. But if you want, introduce yourself. Why not?
Hello,
Khalid.
John.
Go ahead, Khalid. Hey, okay, Manuel. Okay, take it. Okay, Manuel.
Well, my name is Manuel. I'm resident of second year resident in neurosurgery in Moscow.
Yeah, you know he's a Latino in Russia. Latino in Russia.
Yes, that's true. That's true.
Yeah,
very nice.
You're from the Dominican. You're from Dominican, right?
Huh?
Yes, I'm from Dominican Republic. Later, I moved to Venezuela, and Venezuela situation is not the best one. And then I moved to here, to Moscow.
Oh, okay. Okay. Yeah, we're doing grand rounds in Latin America on Sunday. I know you're busy as heck, but I'll send you the poster.
Yes, today I am in duty today. I finish tomorrow.
Oh,
I'm in hospital now.
Oh yeah, no, it's Sunday. Sunday at noon in Moscow. That's a different time, of course. But at noontime in Mexico City. So
okay.
So sí, hay otros latinos en Rusia también. Tú conoces el otro Oscar, ¿verdad?
Oscar. Yes, but he's not here anymore. He go back.
Oh yeah, él me roba, so headphones. Oh man, yo dice, por favor, da un congreso, da un chala, no es un regalo de Navidad. Okay. Hello, Khalid.
It's happening.
Yeah, that's life, you know.
Hi, John. How are you?
Hi, Egg. There's the man.
Hey,
This colleague.
how are you?
Introduce yourself to whoever's
Yeah,
here.
I'm Khalid from Kenya. I'm 5th-year resident in neurosurgery. Yeah, was a very good session. Great masters, big guys today, and a big audience of almost 70, I guess.
Yeah. We're cooking. We're cooking.
Yeah, so that's a big crowd.
Yeah, we're cooking.
Yeah, it's getting better and better.
Well, I'm glad there weren't any big technical issues today. Thank goodness.
And Professor Vlad is a very good teacher.
Oh,
he taught us in Zanzibar.
Oh, he loves it. He loves this. He loves this.
He taught us in Zanzibar. What was it? Was 2 years ago?
Well, I don't know. He's a well-known guy and teacher.
You can see the picture.
Yeah. You're with
That's
Shaq O'Neal there.
Gonzalez.
Shaq O'Neal.
Yeah, that was. No, the Shaq O'Neal guy is a different guy from Tanzania.
Oh, okay.
Professor. Yeah, but you taught us in Zanzibar 2 years ago.
Oh,
Gonzalez. Yeah.
Okay.
You'll see tomorrow. He's a very good. He's a very good teacher.
Yeah, he likes us. He's gonna, I think, be coming back a lot because he's got. Some people don't want to travel. So much.
Oh, he travels a lot.
So maybe he's in that position where, hey, I'm getting tired of traveling. I want to teach online.
Yeah, and he's a very funny guy also.
Oh yeah. I met him in Nepal.
Oh, you met him in person?
In Nepal. Yeah, in Nepal.
Ah, okay.
He was there. I went there for 3 months, and he came for a conference there.
You were in Nepal for 3 months doing?
Yeah, I was there. Yeah, I was there when Yuha was there.
Oh, for 3 months.
Yeah, for 3 months.
Oh, okay.
Yeah, and I interviewed Yuha for Finnish television, and he made some presentations from Nepal. And then he went to China. He kind of lost touch a little bit because I had a hard time hooking up with the Chinese technicians because of the language problem. And it's my problem, really. I don't speak Chinese, but there's not many people that spoke Chinese at the hospital or English. I mean, English. So it was hard to set up anything,
Yeah.
Hey, Victor, where you been? ¿Dónde estaba? ¿Está durmiendo?
Yeah, I was sleeping. Estaba durmiendo.
Oh, como Rip Van Winkle. Para 2, 3 meses.
Estaba hibernando como los osos.
Oh, okay.
I was sleeping with the beard.
Yeah, okay, the pandas. Okay, ¿cómo estado?
Bien, muy bien, adiós, gracias.
Okay.
Very nice to see all of you.
Okay, hey, Victor, introduce yourself to people.
Victor Hugo from Mexico City. I am a brain surgeon, a skull-based surgeon, and anatomist. I like too much to make research about brain and spinal arteries and also veins.
Victor, can you show a slide or two? Not too much, just a little, just to show what you do, okay?
In a video.
What time is it, Victor? What time is it now?
Now in Mexico it's almost 8 o'clock.
In the morning or in the evening?
Morning.
Yes.
Same as Miami. Yeah, Victor, just 1 or 2 slides, very short, because there's a lot of people I think like to meet.
Okay, is to put.
But I want to show you guys the work that Victor does in neuroanatomy.
Let me try with this because. Okay. No, wow. I have to connect my hair disk. Let me see.
Well, Victor, you could always do a presentation.
Yeah, I can make a presentation about spinal arteries.
Yeah, we'll do that. We'll talk later, okay?
Yes, of course, yes.
Okay, great. Anybody else that wants to introduce themselves? Sarik from Kazakhstan. Hello, Sarik. could you please introduce yourself? Go ahead, Surik, unmute. Let me unmute you. Go ahead. Surik, well, I can't unmute you for some reason with your kids. Say hello. Hello there in Kazakhstan.
Hello.
Hello, how you doing today?
Hello.
Yes, we can hear you. We can hear you.
Fine, sorry. Fine.
Could you please introduce
I
yourself?
am Sir December. I used to work in China as a neurosurgeon.
Okay. And now?
And I came to Kazakhstan to work in Kazakhstan.
Okay, welcome. We hope you participate more.
Thank you very much.
How about Bastian Matos? Are you there, Bastian? To introduce yourself there? I don't know.
Do you hear me?
Yeah, go ahead. Hi, could you please introduce yourself?
I'm Bastian Matos. I work in the University Hospital in Ljubljana. My chief is Professor Roman Bosniak.
Oh, welcome. Yeah, welcome.
I see him now.
Yeah, you are welcome to participate in all our presentations. Okay, and anybody else? Jose Amar. Are you there? You want to introduce yourself? No. Okay, Anderson, Louise Anderson. Just want to give everybody a chance to introduce themselves to other people. Dwayne, are you there? Dwayne? Well,
hello, Dr. Bennett. I'm here.
Go ahead, please introduce yourself.
My name is Darwin Chimba. I'm a medical student from Copperbelt University, Zambia. I'm so glad to be here. Thank you very much.
Okay, and Dwayne is starting a medical school channel in Africa, covering. You want to say a word about that, Dwayne? Dwayne, do you want to say a word? Go ahead.
Sure. So the medical school safari, it's something that is basically intended to promote medical education among medical students around Africa and beyond Africa. So we hope to generate and disseminate information among medical students and make it easy for medical students to understand various topics. So we'll be having discussions on Zoom like this, where several medical students from all over the continent and beyond the continent can contribute something, and we have those discussions. Okay, so basically, that's about medical school safari.
Yeah, there's your studio, Darwin. You can see it, right? Okay, when Darwin, he's going to put together a community of medical students in Africa, and you can see the screen, right, Darwin?
Yes, I can.
Yeah, that was his first program on portal hypertension. So, okay, very good. Anyone else in the panel here? Roman, how you doing, Roman?
Hi, I'm from Slovenia, Roman Bosniak, and I work together with Boštjan Matos. We are from the same department.
Oh, great.
Slovenia.
Great, welcome.
Yeah.
That's the what's the approach that the person from Slovenia, the something approach, I'm not a neurosurgeon. The approach, it's someone from Slovenia.
Dolenz approach.
Yeah, that's it. There you go. That's
Dolenz was chief for our department for 25 years.
Oh, okay. Yeah, that's how I
so
came.
Me and Boštjan are pupils of him.
Oh, great. Welcome. Anyone else that wants to introduce? Erico, Alex, Alexis, Jose, Stuart Portilla from Ecuador. Sarik, we met you. Bastian. Okay. Well, Abraham, you introduced yourself early. Introduce yourself again. Why not? It's free.
Hey, I'm Ibrahim, medical student and PhD student from Berlin. And
are you a neurosurgeon to be, or just kind of dabbling in it?
No. I mean, I've chosen medical school to become a neurosurgeon.
Oh, I'm sorry. I'm already I'm already graduating you.
It's good to see you again, Dr. John.
Yeah, well, it's good. It's good you're so active in social media, because I think it's an asset to your education, and obviously it's an asset to your networking. I mean, look at the people you met. And all these other people. And
right, it's becoming quite crowded here. I mean, we had I think almost 70 panelists today.
Well, of course, it was Juha that was the big draw, but now people have time at home a lot,
right?
Which is unusual in history, and obviously it won't be as in demand once people get back to their job. But people will get a glimpse of what it is during this time and get to see what it can do. I think, right? And I think they'll go away from this Corona thing with an appreciation of video as a communication tool.
Absolutely,
for many reasons. But Juha liked it from the start. When we in Nepal, when we were there, we started doing them. So he knew from the start, and I hope we can get more communication with him, because everyone in the world knows who he is, just from the first name, like Cher, like a singer. Everyone knows. You say Cher to someone, they know who Cher is. And same thing with Juha. Let's see here. Anyone else wants to introduce themselves? Yeah, that's the value of this platform.
I haven't heard Stuart talking today.
To what?
Stuart.
Oh, Stuart Portilla?
Yes, right. It's been a while.
Yeah, you remember Stuart?
Yeah, of course I remember Stuart.
Okay, Stuart, but I guess he said he's working in the hospital, a lot of construction and stuff like that, the noise. Right, Stuart? I think you can text. But we're starting that African medical student channel. And of course, everyone's welcome to participate. But, we'll grow. I think the way to start is with the basics, because most medical students, I think, feel they have to present clinical material. But no, we'll do histology, we'll do anatomy, we'll do, you know what I mean? We'll do subjects that medical students need.
Right.
Online now during this time. So here's Victor. Victor's showing his spinal cord anatomy.
Yes, let me show you this. This is an injection of spinal cord.
Huh?
Look at this.
Yeah, you see that before, Abraham?
Wow.
Yeah, he's a pioneer in this.
Well, I know that, yes.
Well, we know why, Abraham, because it takes so darn long to do this. It's painstaking, and most people just don't have the time. But to someone dedicated to it, they have the time on it. Yeah, he's wowed audiences coast to coast.
Amazing.
Yeah, this is an injection of spinal cord veins. Yes.
Yeah, you have 12 neurosurgeons here and students here, Victor. So if you want to just tell them.
Do you like it?
If anybody has any questions or comments, go ahead, jump in. This is informal. You lost the screen there, Victor.
Yeah?
You lost the screen. Yeah.
Do you want to see another one?
Oh, I don't know. It depends. Anybody out there have any
Yeah.
comments, requests, or something of Victor?
По-моему, отпрene. Pa imaš kamero pa lahko.
Well, Victor, if you want to, yeah, please show some more. Please, I mean, they're interesting to the people, I think, here. I mean, you got 12 neurosurgeons here, Victor. Give it a nut, and well, maybe some students mixed in, and a couple of students mixed in.
Yeah, I can show you this one. Can you see it?
Well, not yet. Not yet.
Not yet?
Not yet, no.
Okay, let me try again. Let me try again. I think I lost the connection.
Oh, okay. No big deal.
Oh. Yes, I lost the connection. I think so.
Oh, really? Why isn't your screen going down if you lost your connection?
I don't know what happened.
Okay. Well, no big deal.
Okay. Okay.
So you're at home now, Victor?
Yes, I'm at home.
Okay.
Can you see it? No.
Not yet.
Not yet.
If you want to, well,
let me show you.
There you go. There you go. Starting. There you go.
Yes.
Yep.
Okay.
People can make comments if they want. This is very informal.
Yeah. Yes, this was yes. Yeah, this was the audio, the video, Dr. Bennett.
Oh, okay. What the audio is good down?
Thank you, Dr. Perez.
You're welcome.
You have a neuroanatomy lab, right? In Mexico City.
You have one at home. I think he has one at home, right, Victor? You have one at home and you have an office, right? I guess he's concentrating on trying to get that going.
I don't know what happened with the.
Don't worry about it, Victor. Don't worry about it, Victor.
Yeah.
Yeah, we can do presentations. So okay, great. Yeah, Victor. Like to get you back. Like me gusta que tú haces más congresos, más charlas. Okay, Victor.
Yeah.
Okay, ahora es el tiempo. Ahora es el tiempo bueno. Ahora.
La conexión es algo inestable, John.
Sí, sí. Ok, Victor, vamos a hablar más tarde, ¿ok?
Sí, yes,
okay,
of course.
Ok, tengo que ir, ok, Dwayne, Stuart, todo, ok, chao, todos.
Yeah. See
Okay,
you.
yo voy a mandar un link, Victor, ok?
Yes.
Okay.
Thank you so much.